patients have to preserve ejection fraction, 60 to 90% remain in preserved ejection fraction, 10 to 20% either go to heart failure mid-range ejection fraction or less than 10% go to heart failure reduced, gradually deteriorate. With mid-range ejection fraction, mostly they stay in mid-range ejection fraction, but 20 to 30% go to preserved ejection fraction, further improvement, and 10 to 20% can also deteriorate to reduced ejection fraction. In patients who have a reduced ejection fraction, 60 to 80% remain in reduced ejection. However, these 20 to 30% what remain, they can improve to mid-range or improve to preserved ejection fraction. Here mid-range is 40 to 50, preserved is EF more than 50, and reduced is less than 40. If the ejection fraction improves, the improved ejection, recovered ejection fraction, whether are going to continue ARNI or not, what the guideline says. Guideline says in patients with heart failure improved ejection fraction, after treatment, GTMT should be continued to prevent relapse of heart failure and left ventricular dysfunction, even in patients who may become asymptomatic. Even if the EF improve, even if there is a patient is asymptomatic, we should continue ARNI. Otherwise, there may be chances that there may be development of relapse of heart failure and there may be LV dysfunction. So after this, we will come what are the pearls of consensus. These two slides are very important. You must concentrate these two slides. ARNI is molecule of century and is indispensable and superior to ACE inhibitor in reducing the cardiovascular death, heart failure hospitalization, sudden cardiac death in patients who have reduced ejection fraction. Because the sea change in the treatment of heart failure has come after the paradigm heart failure trial in 2014, where ARNI was found to have to reduce relative risk reduction of death and heart failure hospitalization 20% over and above 17% of NLRP. Because this is a trial where ARNI was compared to NLRP. This is not compared to placebo. Many times there is an active comparator. Other studies will find the ARNI, other than ARNI, say other studies, they will compare to placebo. Placebo means somebody taking 3 drugs, these are guideline medicated drugs, plus placebo one arm, other arm is another active drug. Here, 2 arms had active drug. One arm had 10 milligram of NLRP twice daily, and ARNI here 200 milligram twice daily. So over and above 17% benefit of NLRP, there are 20% further benefit. If you take out, if trial would have been compared with placebo, there would have been 37% reduction in the heart failure hospitalization or mortality. That is why there is so much of benefit for the found patient with ARNI. So ARNI also improves left ventricular ejection fraction in heart failure reduced ejection fraction and reverses the adverse LV remodeling and improves quality of life. This is very important. Even the studies came up prior to that. We have seen in our practice patients taking ARNI having improvement in quality of life and improvement in ejection fraction. That came late from evidences that these are possible. So not only it reduces the mortality, not only it reduces heart failure hospitalization, it improves ejection fraction, improves quality of life. ARNI should be initiated as early as possible in patients with acute decompensated heart failure and de novo heart failure patients. As we know, as what the trial shows, in acute decompensated heart failure, once the patient is stabilized in hospital with the diuretics, then ARNI should be started pre-discharge and should be optimized on OPD basis. And de novo heart failure, ARNI should be started to prevent decompensation, to prevent further deterioration. ARNI should be given for at least 3 to 6 months along with other foundational therapy for heart failure reduced ejection fraction and LVEF reassessed with echo and CMRI, cardiac MRI, before the considering ICD or CRT in such patients. So what we were discussing earlier patients after AMI 42 days, where EEF remains still less than 35, dilated cardiomyopathy with wide QRS, patient not improving standard care therapy, we are considering putting ICD or CRT. Now, the guideline says without giving a trial of ARNI, one should not advise ICD or CRT, because they have seen after the use of ARNI, many patients have not needed ICD or CRT, they have improved. ARNI should be used in all patients with heart rate preserved ejection fraction up to LVEF 57 to 60%, along with SGLT2 inhibitor to reduce heart failure hospitalization and quality of life. As we saw, the studies showed there is reduction in heart failure hospitalization, improvement in quality of life, though it has not shown to be beneficial in reducing the mortality and improving the survival.